So, good evening, everyone, and welcome to today's webinar on beta blockers at the crossroads of hypertension and heart failure. So, as we always all know that cardiovascular disease remains the leading cause of death worldwide, and hypertension continues to be its most important modifiable risk factor, which accounts for the prevalence of about 35.5% as per the ICMR India study. Also, hypertension is the leading precursor for heart failure also, and heart failure accounts for about 64 million people worldwide. Now, the challenge in today's clinical practice is just not just achieving the BP blood pressure targets, but also choosing the therapies which can improve the long-term cardiovascular outcomes. And this is where beta blockers occupy a unique position. So in today's session, we will learn about the evolving role of beta blockers and their optimal use at the intersection of hypertension and heart failure. So today we have with us our esteemed speaker, Dr. Jamshed Dalal sir, who is Director and Cardiac Sciences at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute in Mumbai. Sir has 40 plus years of experience in field of interventional cardiologist, and he is renowned with several institutions abroad with like National Heart Hospital London and all. Also, sir has been awarded with many awards and honors of Cardiology Society of India Prize for Distinction and Young Researcher Workers Award also. So, without further ado, I will hand over this session to Dr. Jamshed Dalal sir, and we are looking forward to learning from you, sir.
Thank you very much, Dr. Kirti. I'll share my slides and we can start off. Can you allow me to share, please? Yeah, thank you. Right. So I hope you can hear me and see my slides.
Yes, sir. Yes, sir.
Yeah. Okay. So today we are going to talk about beta blockers. Now, beta blockers have been there for a very long period of time, as you all know. So why are we talking about them again? I think one important factor to remember about beta blockers is that the majority of beta blocker trials were done decades ago, at a time where new therapies were not available. Most of the beta blocker studies were done, for example, when heart failure new drug therapies were not available, angioplasty was not available. So there's a lot of change now with the new therapies, and we want to look at how beta blockers are now placed in view of the modern medical therapy and modern interventional therapy as well. So we're going to talk a little bit about the pharmacology and mechanism of beta blockers. What is the link between hypertension and heart failure? And you know very well, one of the commonest causes of heart failure is hypertension. And look at some of the old evidences of various beta blockers in heart failure. And then look at bisoprolol particularly, because I think it's a little bit different from the other beta blockers. And then how do you put that all in practical terms? Now, we all know hypertension, which is a very common denominator for the development of heart failure, and again, a very common problem by itself. As you can see, over 1 million adults worldwide have hypertension, a huge hypertensive population in India as well, and it forms a very leading modifiable risk factor for cardiovascular death. It increases the left ventricular afterload, as you can well imagine, that produces left ventricular hypertrophy and eventually diastolic dysfunction and heart failure. Now, if you look at heart failure, it's now divided into heart failure with reduced ejection fraction, mid-range ejection fraction, and preserved ejection fraction. Anything less than 40% would be reduced, anything more than 50 would be preserved, and between the 41 to 49 would be the mid-range. Of course, if the ejection fraction is low, really we don't need a BNP or any other evaluation for making the diagnosis. But usually in heart failure with mid-range, and especially in heart failure with preserved ejection fraction, where the ejection fraction is more than 50%, you need some other evidence. Clinical evidence of heart failure is very important. Symptoms of heart failure are important. And in addition to that, evidence of diastolic dysfunction on echocardiography and the elevation of BNP. So, what are the hemodynamic determinants which implicate heart failure? First is a fall in cardiac output that leads to increased filling pressures, that leads to neurohormonal activation, which is where the beta blockers come into picture. And then, because of this increased filling pressure and the neurohormonal activation, you get a maladaptive remodeling That means adverse remodeling worsens the heart function. So normally when we talk of remodeling, we talk of things getting better. But here we talk of a maladaptive remodeling where the LV function deteriorates. When you talk of heart failure, we usually concentrate a lot on left ventricle, which I think is important, of course, but don't forget the importance of RV as well. LV and RV functions go hand in hand. LV dysfunction causes pulmonary hypertension, which increases RV failure. RV failure produces tricuspid regurgitation, which worsens right ventricular failure. And RV failure associated with increasing tricuspid regurgitation is a very important contributor to worsening cardiac output, worsening heart failure, and is an important factor in heart failure deaths. Now, sympathetic overdrive is what links hypertension and heart failure. So, you have hypertension, you have chronically elevated afterload, then you have sympathetic overactivity because of that, and then eventually leading to both adrenergic crisis and RAS activation. So, adrenergic plus RAS activation causes the remodeling and decompensation. Now, we all know this very well. Beta blockers are beta 1 and beta 2 because beta 1 receptors predominantly in the cardiac and renal, beta 2 receptors bronchial, uterine. So, you want something which is more beta 1 rather than beta 2 because you're not interested in bronchial. In fact, it makes the asthma and things worse. You're more interested on the effects on the kidney and most possibly on the heart. Of course, they affect the chronotopy, reduce the heart rate, and affect the AV conduction. So, you need to really remember that. They also stimulate renin release from the kidneys. So I think it's important to remember that they are beta 1, beta 2 receptors, and different beta blockers are more or less selective for beta 1. So you have beta. So how do the beta blockers act? So you have a receptor blockage because of the beta blockers. You got a reduction of cyclic AMP and a reduction of calcium influx. Then you have electromechanical effects, reduced sinus rate, reduced AV conduction, and reduced contractile force as well, and effectively leading to a lowered myocardial oxygen demand. And therefore, the lower demand, lower adrenergic drive has a beneficial effect on cardiac function. So, how do beta blockers work in heart failure? They reduce cardiac output, they cause a remodeling drive benefit. They produce the beta blockade, which reduces the inhibition of sympathetic activity. And overall, this reduction of the sympathetic activity, the effect on the norepinephrine drive improves contractility and reduces this adverse remodeling. Now that we've established this sort of a background, let's look at some of the beta blockers per se. So as we said, you have first generation beta blockers, which is what we started off when we were students, propranolol, which is both the beta 1 and beta 2. Then you have the second generation, which is the beta 1 blocker, along which is bisoprolol, metoprolol, and atenolol. And you have a third one, which is carvedilol and nebivolol, which in addition to beta blockade, also have an alpha 1 blocking, producing vasodilatation. So obviously you do not want propranolol because it affects beta 1 and beta 2. You'd prefer a pure beta 1 blockade, which is bisoprolol, metoprolol, atenolol. And you would even more prefer, especially in heart failure, the third generation, which also produces vasodilatation. And that is beneficial in patients with hypertension and heart failure both. There are a large number of trials, as you know, these were done decades ago on the benefit of beta blockers in heart failure with reduced ejection fraction. Please remember, all the original work was on reduced ejection fraction. At that time, mid-range ejection fraction wasn't even invented. So you had reduced ejection fraction, normal ejection fraction. And all these studies, the Copernicus, the Carvedilol, Capricorn study, so the metoprolol was the Merit study. Carvedilol was the Copernicus and the US Carvedilol study and the Capricorn, and bisoprolol was the CIBIS group of studies. And then you had some evidence of nebivolol, but this was restricted to older patients called the seniors trial. So we have a handful of these trials which have been used. Now, amongst the beta blockers, really you can select anyone you want, to be all except I would think not propranolol because of its uh, more side effects. Metoprolol, a very common beta blocker, cardioselective beta 1 blockade, is available as extension release, so it provides a 24-hour. There is evidence based from the Merit trial, and it is hepatically metabolized. So, in patients with hepatic impairment, be a bit careful with metoprolol. And you start off with 25 milligrams as the minimum dose, and you can go up to 200 milligrams once a day. Carvedilol is non-selective. That's important to remember. Carvedilol is non-selective, but it has alpha-1 blocking effect. So it's non-selective, so not good for asthma, etc. Very good for patients with heart failure because of its vasodilating effect. It has antioxidant properties. There are two large studies, Copernicus and Capricorn, which are in heart failure, showing significant benefits of carvedilol. Again, you can use with 3.125 milligrams, increasing up to 25 to 50 milligrams twice a day. Carvedilol is a popular drug not for hypertension, but for heart failure. And then, of course, your bisoprolol, which is the highly cardioselective. Beta 1 cardioselection is the highest in bisoprolol. It's a once a day dosage, it acts a full 24 hours. That's a big advantage. And it has been proved in CIBIS trial as a beneficial drug for heart failure with reduced ejection fraction. The other advantage of bisoprolol is that it has a balanced hepatic and renal elimination. So it broadens the usability whether you have renal dysfunction or hepatic dysfunction. Again, you can start with small doses of 1.25 and then increase it to 10 milligrams once a day. So a wide spectrum. Just to put that all together in one slide, bisoprolol very significantly beta 1 selective uh, and compared to metoprolol. Again, it is beta selective, but of course, atenolol, which I didn't mention because it's used for hypertension in the past, very rarely used now. It has its own issues, but it's again, many people are on atenolol and happy with it, but it's not the drug which is now the drug of choice or the first beta blocker of choice. And there are certainly no trials with atenolol and heart failure. So, really, for heart failure per se, there is no evidence of the effect of atenolol. So, just keep that in mind. So let's see what is the evidence we have, and let's look at some of the landmark trials that are there. The MERIT heart failure trial was with metoprolol, and these are all in patients with reduced heart function. Please remember, these are all in heart failure with reduced ejection fraction. So the New York Heart Association class 2 or 4, LV ejection fraction, as you can see, less than 40%, about 4,000 patients, endpoint all-cause mortality, and there was a 34% relative risk reduction. So it's established that metoprolol is very useful for reduction of mortality in patients with heart failure with reduced ejection fraction. The Copernicus trial, as I mentioned, was with carvedilol. Again, this was patients who were severely ill. So this was a group of patients who were severely ill. Ejection fraction less than 25%, severe symptomatic. So, as you all know, beta blockers at one stage were contraindicated in heart failure. And now we are using not only for heart failure with ejection fraction less than 40%, but in this trial, severe heart failure ejection fraction less than 25%, something which you'd never have thought of using in the earlier days. Again, a good sample size, 2,300 patients looking at all cause mortality. And guess what? Even in this very severe heart failure patient, it produced a very significant 35% risk reduction in all cause mortality. So, one more drug called carvedilol for heart failure, including very severe heart failure. And then, of course, a CIBIS trial with bisoprolol. You can see the ejection fraction is less than 35%. Patients are pretty severely ill, class 3, class 4 heart failure. Again, 2,500 patients, again, all cause mortality as the endpoint. And look at the left again, the key outcome 34% reduction in all cause mortality, very significant p value. Also, reduction of sudden cardiac death. Now, that's very important. Two things are very important here: reduced hospitalization, which all beta blockers do, and we know that less hospitalization means less mortality. And sudden death is one of the factors which often happens in patients who are not critically ill with heart failure. So, in heart failure, you can die because of pump failure and worsening heart failure, or you can have sudden death because of arrhythmias. So, the beta blockers not only prevent the reduction of heart failure from deteriorating heart failure, but also from sudden death. So, I think it's very important. Also, many patients with heart failure have atrial fibrillation, and beta blockers are very useful for the management of atrial fibrillation in this group. So, again, one more drug which has been very effective. And last, of course, is nebivolol. This is a very specific niche trial. It was in patients who were 70 years who had heart failure history. They had a very long range of EF. So some were low EF, some were normal ejection fraction, because this was a different type of trial. This was a trial of elderly patients with heart failure and how would they benefit from that. And even this group with not very low ejection fraction had a 14% relative risk reduction. So again, a first major beta blocker trial in the elderly across the spectrum of LVF. So it's not a very specific, but a elderly patient. So these trials clearly show that beta blockers work, and all these beta blockers work. It shows that beta blockers work when the heart ejection fraction is less than 40%, and even when the ejection fraction is less than 25%, even in patients who are severe heart failure, and the outcomes are quite significant, including reduction of all-cause mortality, reduction of sudden death, and reduction of heart failure hospitalization. Strong HF study was to see whether you need to start these drugs soon. We know all that we have four pillars plus vericiguat now available for treatment of heart failure patients. And this study looked at whether you should start them at slow speed or should start them rapidly. So it's always important to start all these drug therapies rapidly. So beta blockers should not be waited upon as the last line of the pillars. It should be started as soon as possible, particularly so if heart failure is associated with hypertension, tachycardia, or ischemic heart disease, then beta blockers become even more important. As you can see from here, the earlier you start the treatment, greater the benefit these patients have. Now, if you look at all these beta blocker trials, leave seniors alone because that's a different type of trial. But if you look at Merit, Copernicus, and Cibis, and you can see again a pretty significant and almost similar reduction. So many times people ask which beta blocker to start. Well, evidence-wise, all of them produce similar effect. You can choose them depending on once a day or multiple times a day. You can choose them on the basis of renal dysfunction, hepatic dysfunction, or whether hypertension is present or not. So bisoprolol, highly selective compared to carvedilol. That's the important thing to remember. So in heart failure, carvedilol has the advantage that it's got vasodilatory properties because of alpha-1 vasodilatation. Bisoprolol has the advantage of being beta-1 selective. Bisoprolol has a balanced hepatic and renal, and carvedilol predominantly has a hepatic. Bisoprolol can certainly be given once a day. Carvedilol is often given twice a day. And if you compare it with metoprolol, again, it is less selective beta blocker compared to bisoprolol, but it's again highly lipophilic. It acts through hepatic. So remember, in hepatic dysfunction, be careful. The long sustained tablets, you can take metoprolol once a day as well. There have been some trials comparing bisoprolol over metoprolol. This is a Chinese trial which has looked at the two and has suggested that patients treated with bisoprolol had a greater blood pressure and a heart rate reduction. So yes, bisoprolol has a much longer acting effect. It can be taken once a day. It doesn't have any effect on central aortic pressure, which has a effect on central aortic pressure, which is a very good thing to do. So these are some of the marginal benefits of bisoprolol. This is an Indian trial looking at bisoprolol versus uh, metoprolol, and again, some advantage of bisoprolol clearly in terms of more reduction of blood pressure, more patients who take it, less side effects certainly, and less bradycardia as well. So clearly, all drugs can be used, but bisoprolol has its own advantages, and particularly in those with uh, hepatic or renal insufficiency, when you have a drug which is cleared by both, then clearly that's important. So when you use beta blockers, see whether the patient has hepatic or renal insufficiency. Elderly patients, of course, be more careful, start with smaller dose. Patients with diabetes, we all know that non-selective beta blockers can provoke increased blood sugars. And of course, patients with COPD are not contraindicated. Patients with acute asthma, there's definitely contraindicated, but a patient with chronic COPD, there is no contraindication. Also, we know that nebivolol, cardioselective, we know bisoprolol, cardioselective. So clearly these drugs would be more beneficial, and you certainly would not use drugs like atenolol or propranolol in these patients. So, so you have patients with hypertension, coexisting heart failure, either post-MI or not. I'm going to talk about this a little later about what to do with patients with post-MI and beta blockers. Then renal impairment and advanced stage, be careful about drug clearance. COPD, not a contraindication. Asthma, yes, a problem. And again, for long term, we want once daily dosing. So if we look at the indications in hypertension per se, actually it has been very debatable. Nobody puts beta blockers as a first line drug of choice. So mostly the first line drug of choice is either an ARB or an AC inhibitor, along with either a diuretic or a calcium channel blocker. So all guidelines would suggest that as the first. Now we know today in treatment of hypertension, there's nothing like first drug, second drug. The aim today is to use a combination of drugs in small doses. So clearly people will combine ACE inhibitor with diuretic, ACE inhibitor with calcium channel blocker, or all three together as one single pill. And of course, if the BP doesn't come down, then clearly you have to think of something else. At that point in time, definitely beta blockers are very useful. So beta blockers remain one of the core, but not necessarily the first line drug of choice in the patients with pure hypertension. We're talking about simple, pure hypertension. However, if the patient has coexisting heart failure with reduced ejection fraction, completely changes. Beta blockers become extremely important and probably should be one of the drugs within the combination of the first set of drugs. If you have prior myocardial infarction or coronary artery disease, then that's a compelling indication both for treatment of angina and for management of the coronary artery disease. If the patient has atrial fibrillation or any arrhythmias, ectopic beats, ventricular premature beats, again, beta blockers become an extremely useful, compelling indication for treatment along for treatment with hypertension. So you look at the ESC guidelines, you look at the middle, it is recommended that beta blockers, the middle component, beta blockers are combined with any of the four major other class of drugs. So they put that as a class 1A indication, especially in patients with angina, post-myocardial infarction, heart failure, or reduced ejection fraction, or even those with tachycardia. So in those groups, it's the class 1A indication. If you look at the American Heart Association guidelines, they are less prone to prescribing beta blockers. So as you can see from here, beta blockers doesn't come as the primary group of drugs. Certainly, it would come in as an additional drug. And if there are no compelling indications, then it would come in when you have uncontrolled hypertension, in spite of using the drugs, or patients do not tolerate some of these drugs. Patient gets bad cough, for example, with ARB, a lot of leg edema, and cannot tolerate these, then of course beta blockers would be a part of the treatment. But again, as I mentioned, when you're using a combination of drugs in small doses, I think beta blockers would play a very important role. This is just a real world trial from India called the Robust trial, looking at the beta blocker use in India. And believe me, beta blocker use in India is very high still. Even for the management of simple hypertension, beta blockers are commonly used because they're easy to use, they're not expensive, they do not have much side effects. And many of these patients, particularly the young hypertensives that we see in our country, they often have a lot of sympathetic overactivity. They're anxious, they're tachycardic. And in this group of patients, beta blockers can be a very important drug for use. This so clearly robust trial from India showed that beta blocker use consistently remains high in spite of all the evidence. So let us look further. So how do we initiate? So beta blockers, as far as heart failure is concerned, should be started, as I mentioned, along with other four pillars. So you have four pillars, as you know, the MRAs, the RAS blockers, SGLT2, and the beta blocker. So these are the four pillars which have to be started at the same time. Again, initiate all the four pillars as soon as possible. So if patient is admitted for heart failure, as soon as the patient is out of the ICU, start introducing the drugs. And according to me, make sure the patient is on all the four pillars before the patient leaves the hospital. Yes, you can then adjust the dosages as you require. But if you send the patient home without one of the pillars, say you say, okay, I'll try beta blockers later, chances are it will be prolonged too much. And we know from the trials that the early starting of all four drugs is very beneficial to the patient. Also, please remember, even in severe heart failure, beta blocker is not a contraindication. Because often people do not start saying patients say heart failure is too severe, ejection fraction is too low. But no, as long as you treated the congestion, patients not in pulmonary edema, patients adequately diuresed, beta blockers will and need to be started as well. Obviously, if you have second or third degree AV block, be careful. If you have critical limb ischemia, you don't want more vasoconstriction. If the patient's got severe asthma, that would be not COPD, but certainly uncontrolled asthma. So these would be a few of the contraindications. If you use bisoprolol, it's easy. If the blood pressure is low, the heart rate is low, patients in heart failure, very low ejection fraction, you could start with a very small dose of 1.25 milligrams, and then every weekly you can increase to maximally tolerated or up to 10 milligrams. If you look at the ACC and ESS guideline for heart failure, then clearly beta blockers is a class 1 level A recommendation for heart failure with reduced ejection fraction. So reduced ejection fraction, now there is no doubt AC inhibitors, ARBs or ARNI, and I would say ARNI should be the drug of choice. MRAs, SGLT2 inhibitors, and beta blockers. Clearly, all four need to be done. And of course, the Indian consensus statement on heart failure clearly supports all that and has no doubt that there is no discrepancy in guidelines between the American, Indian, or the European society. So all guidelines are now pretty much accurate. Now, the question is long term beta blocker therapy after myocardial infarction. Now, as I mentioned, most of the beta blocker trials which were done on patients with myocardial infarction, as you all know, we have been told that if you have an infarction, start the patient on a beta blocker and let him be on beta blockers for the rest of his life. And many of my patients have been on beta blockers for 20, 30 years after they've had their heart attack. But clearly now that was an era when there was no thrombolysis, there was certainly no angioplasty. So that era was different. The heart attack often, infarct often resulted in a reduced ejection fraction. So usually the beta blockers were effective because majority of these patients landed up with poor ejection fraction because they were not really treated. They were just symptomatically treated with nitroglycerin, etc. But now, with say you have an infarct and you have an angioplasty within an hour, and your heart function is pretty much preserved, do beta blockers have any benefit or not? And there have been a number of trials looking at that. And though the data is limited by the observational methodology used, the majority of included studies failed to demonstrate a benefit in survival or cardiovascular events with long-term beta blockers in post-MI patients with normal ejection fraction. So if you've done an angioplasty, patient's ejection fraction is virtually normal, he's had a myocardial infarction, yes, you may start him on beta blockers for a short time, maybe up to a year. There's a bit of, you have to make, I think, an individualized call as to whether you should continue for a year or not. But clearly, that much you can continue. But certainly, I think more and more evidence is there that if the ejection fraction is normal in the post myocardial infarction era, there's no point in continuing beta blockers indefinitely. So that seems to be now more or less standard thinking. Now, there are a number of trials which looked at patients with preserved ejection fraction after MI to see how they benefited or not, so as I mentioned to you earlier. So, if you have a reduced MI trial, a reduced AMI trial, that is beta blockers after myocardial infarction with preserved ejection fraction. It's an open label trial, 5,000 patients. They're in acute MI, they're in urgent angiography and angioplasty, and the ejection fraction more than 50%, and they had no heart failure. And the endpoint was death from any cause or a new MI. And they found that there was no difference between beta blockers and no beta blockers. So clearly, this is the first large randomized controlled trial to question routine beta blocker use after myocardial infarction with normal ejection fraction in the modern reperfusion era. So, as I mentioned, you do immediate reperfusion, LV function is normal, there are no arrhythmias, no evidence of heart failure, then giving beta blockers may not have any benefit for this particular group of patients. There's another trial called the ABBIS trial, which looked at the other way around. It was a multi-label trial. Patients had myocardial infarction long time back. They were stable for the last 6 months. Ejection fraction was more than 40%. Again, 4,000 patients. Again, looking at multiple factors in the primary endpoint. And if you look at the three endpoints, stopping patients in this particular category had some sort of a problem. So stopping did not improve the quality of life and was not beneficial to the patient. So this trial suggested that if your ejection fraction was 40%, so now we don't know exactly whether it was more 40 to 49 or whether it's more of how many patients were completely normal. The evidence more or less suggests that between 40 and 49, yes, there would be some role. In patients who are completely normal ejection fraction, above 50, 55, 60%, there'd be very little role for beta blockers in that situation. The question is whether somebody is on a long-term beta blocker, would you stop it? The ABBIS trial suggests that be careful, especially if the ejection fraction is a little on the lower side. It's not below 40, these are all equal to or more than 40. And then you have another BETAMI trial, which is in patients with ejection fraction more than 40%, no clinical evidence of heart failure, post-MI. So these are all post-MI patients. Again, almost 5,500 patients, composite of death and adverse reactions. And it showed that at lower risk with beta blockers, pooled meta-analytics looked at this. And what did they find? No benefit in patients with ejection fraction above 50%. So apparently, conflicted trial agrees once stratified by LV ejection fraction. So what I'm trying to reiterate again is that if your ejection fraction is totally normal, probably beta blockers do not have any beneficial effect. And we are talking now only of post-MI patients, where normally we give beta blockers to everybody. So I think in the present era of treatment, along with angioplasty, in patients who have normal ejection fraction, beta blocker has not been proved to useful. Patients with ejection fraction less than 40% definitely and must be used. And some benefit is definitely there in the patient in the mid-range ejection fraction between 40 and 49%. So this is the meta-analysis of multiple trials, beta blockers after myocardial infarction in mildly reduced ejection fraction. That's the 41 to 49%, that between 40 and 50%, and looking at multiple randomized trials. I mentioned some of these trials already, and this one looked at Reboot, Bitami, Namlock, and Capital RC. These were the trials which were included. Patients were almost 2,000. All of them had MI, and all of them had ejection fraction 41 to 49%. The primary outcome was the composite of death, new MI, and heart failure. And the conclusion was that in patients with acute MI and mildly reduced ejection fraction, that is in the mid-range ejection fractions, without heart failure, beta blocker therapy reduced the composite outcome of all-cause death, recurrent MI, and heart failure. Therefore, these findings establish the benefits of beta blockers in patients with mid-range ejection fraction, again suggesting that anybody with a myocardial infarction whose ejection fraction is below 50%, that means the ones below 40, we all know, reduced heart function, heart failure, you have to treat them. Between the 40 and 49, where there was a debate, this meta-analysis confirms that beta blockers will be useful and should be useful. And patients with totally normal ejection fraction, more than 50, 55%, they do not benefit from beta blockers as so far as we have studied. So to summarize, post-MI beta blockers, where does the evidence stand now? So clearly, benefit remains in MI with reduced ejection fraction or clinical heart failure. Remember, some people may be having clinical heart failure because, after all, heart failure is a clinical diagnosis. You don't make a diagnosis only on the basis of echo. It's a clinical diagnosis. There should be signs and symptoms of heart failure when the patient presents. So if you have clinical heart failure and the EF is less, there is no question. There's definitely a positive signal for the benefit of beta blockers in the mid range between the 40 and 49%. So clearly, I would use beta blockers in this group as well. Third, as I mentioned from that ABIS trial, suddenly stopping a chronic beta blocker patient may precipitate some problems. So patients been on beta blockers for a long time, it may be very closely watched if you want to stop the beta blockers and pay very close attention to the ejection fraction. Where routine use is now questioned, post-MI patient whose ejection fraction is more than 50%, who has no heart failure, there is nothing to suggest reduction of death or reinfarction. So in patients with normal ejection fraction, no heart failure, even if they've had an MI, no indication for beta blocker. There is some guidance which now suggests that you could use it up to 1 year. So when you have this doubt, patient's ejection fraction is just about, like, say, 48%, not 49, or somewhere around that time, or was 45% when the patient had an infarct, but within 15 days became 50%. Then these are the patients where there's always some doubt remaining. They have had angioplasty done, but there are lesions in other vessels. They also have associated some high blood pressure. So I think in those patients, it may be worthwhile reassessing up to the period of 1 year. So clearly, I think in this sort of patients who are neither here nor there, everybody doesn't sit into one category. I think there is some role of beta blockers as well. And you must clearly remember that many of these are changing scenarios. The patients who had MI, whose ejection fraction is low, may either improve ejection fraction or may worsen ejection fraction. The patient may get hypertensive or hypotensive. The patient may get arrhythmias, may get history of congestion. So these are the factors that you have to decide. So you can't make a single decision at a single moment and stick to that. So watch your patient and change your treatment as indicated. And of course, if the patient has angina, hypertension, or arrhythmia, and you're using beta blockers primarily for that, then there is no question that beta blockers will be useful. Now, when you're talking of the mid-range ejection fraction, and these are patients who have not had myocardial infarction, who just have heart failure. The previous slides were all post-myocardial infarction patients. These now are the practical takeaways on patients with mid-range or preserved ejection fraction who not had a myocardial infarction history. So benefit has clearly been established in those with low EGF 40%. One of the four pillars, we've discussed that many times before. The evidence between the mid-range and the preserved ejection fraction is quite observational in the patients, not in the post-infarct, but just the routine heart failure patients. And benefit is seen in post-MI, but not in those who have not had an MI. Patients with ejection fraction more than 50%, hospitalized for decompensated heart failure, there may be some benefit. So if you're borderline heart function, you have been hospitalized for heart failure, yes, there is a benefit. The cohort is more directionally favored towards mid-range ejection fraction than preserved. That means clearly patients with a normal ejection fraction, say more than 55, 60%, there's almost no evidence to suggest that beta blockers are useful for them. Mid-range, yes. Post-infarction mid-range, definitely yes. And patients with mid-range and history of heart failure, definitely yes. But of course, if the patient needs beta blockers for AF control, for hypertension, for prior MI, for angina, then clearly, in spite of ejection fraction not being 55, not being below 40%, there is still a role for that. So I think there's a lot of in between data that we have to read, and we are fortunate that these new beta blocker trials came out, because before all these 4 or 5 trials came out, we really had no clue as to whether we should continue beta blockers or not. We knew that heart failure, reduced ejection fraction, yes, beta blockers absolutely mandatory. But we are quite uncertain about whether to use beta blockers or not in other groups. But now with these trials, it is clear that if you had an MI and if your ejection fraction is in the 40 to 95, 40 to 49 group, or if you've been hospitalized for heart failure, or if you have arrhythmias, then clearly you need to use this patient. So thank you very much, friends. I think I've covered uh, some aspects of beta blockers, which I think has not been discussed, because beta blockers is not something which we discuss very frequently, because we are so busy talking about RNA and SGLT2 and all the modern drugs, uh, Verisigvat, etc., so that we rarely talk of beta blockers. But I think Indians continue to use a lot of beta blockers. There's no doubt about that. We use it for hypertension, we use it for heart failure. But having said that, both in India and abroad, the actual treatment of both hypertension and heart failure remains very poor. Almost 50% of people or more do not get their blood pressure controlled either in India or in the Western countries, and more than 50% of them are not on all the 4 treatments for heart failure. So clearly, there's a lot more that we need to do. And the best thing to do, I would suggest, is that for hypertension, use combination pills with multiple drugs. That is the most effective way to control hypertension. And for high blood and for heart failure patients, start all 4 pillars as soon as possible. Don't start with 1 or 2. Patient feels better, and then don't start. Whether patient feels better or not, all 4 drugs in patients with heart failure with reduced ejection fraction is better for their morbidity and mortality. So thank you very much.
Thank you so much, sir. It was a really very informative session, starting from the basics of beta blockers to the landmark trials and the recent evidence. Everything was like very well explained by you. So, sir, we have some questions. So, with your permission, can we
Yes,
take this?
yes, please.
Yes. So we have first question from Dr. Deepak. So he asked that as Indian patients tend to have increased sympathetic activity, so is there a role of beta blocker as a first line agent in patients with essential hypertension?
Yes, clearly in patients who got, uh, sorry, just one second. In patients who have got sorry, I just remember. In patients who got sympathetic overactivity, clearly there's a role of beta blocker. There is no question about that. Uh, so we all use beta blockers in these patients, especially the young person who comes who's tachycardic, anxious, and his BP is a little bit high. Then beta blockers would have a role to play. However, one must realize that if the patient is young, doesn't mean that beta blockers alone should be used. He may have left ventricular hypertrophy, which would be better treated with RAS blockers, for example. So clearly, beta blockers should not be just randomly started just because the patient is young or the patient is anxious. So clearly, look out for other factors as well. And if the BP is high, then I would suggest, if necessary, combine a RAS blocker with a beta blocker so that you have the benefits of RAS blocker. Don't forget there are definite evidence of benefits of RAS blocker in hypertension in terms of renal protection, cardiovascular hypertrophy reduction, which beta blockers do not have. So clearly that's important. But yes, if the patient's tachycardic, beta blocker would be good as a part of a combination therapy.
Yeah, thank you, sir. Well, agree with this. Uh, then, sir, we have next question by Dr. Nitin, that among available beta blockers, so what are the clinical factors which we should consider we, to choose between the bisoprolol, carvedilol, and metoprolol in clinical practice?
In clinical practice, to be honest, you can use any of the three. All three have got good data, all three are being used. And as we saw from the robust trial, all the drugs are being used. In India, metoprolol seems to be the number one drug of choice from the robust trial in terms of between the three drugs. So metoprolol has nothing wrong with it. It's a once a day drug as long as you use the sustained release preparation. Because I think today one must remember that giving once a day is always going to be better for compliance as compared to multiple times a day. Nobody should prescribe a drug 3 times a day. 2 times is maximum, 1 time is even better. So metoprolol, yes, you can prescribe it 1 time a day. Carvedilol, you have to prescribe twice a day. Advantage, of course, carvedilol has got vasodilatory properties and therefore has got more benefit from that point of view. Bisoprolol has the advantage that it's cardioselective, very highly beta 1 selective, and therefore and can be used once a day. It also has a wide variety of dosages that you can use. So bisoprolol, cardioselective, hepatic and renal clearance, so it doesn't matter, and once a day. Metoprolol, again, commonly used drug, also used in the past a lot for coronary artery disease. So we are very familiar with metoprolol. Again, once a day can be used, hepatic metabolism. So remember that. And carvedilol, as I mentioned, non-selective. So don't use for asthma. Benefit for heart failure because of its vasodilatory property may have to be used twice a day. So there's nothing like one particular drug. You can use these little nuances to decide which one the patient prefers.
Really noted, sir. So as you said now that carvedilol can be used in like COPD but not in asthma. So like what are the like reasons that beta blockers are not contraindicated in COPD but they are contraindicated in asthma? So what are the
Because
main?
asthma is once you don't want beta 2 stimulation because beta 2 create beta you want don't want beta 2 blockade because that's what can precipitate asthma. So if the patient clearly has asthma, then I think I'd be very hesitant to start any beta blocker, especially during the acute phase of asthma or even somebody who's having recurrent acute asthma. COPD is a different ball game altogether, and a chronic COPD doesn't necessarily have severe bronchoconstriction, etc. And watchfully, you can use that. You can use nebivolol in these patients. You can use bisoprolol in these patients, which is more cardioselective rather than something like old ones like propranolol used to have a lot of problems with asthma. So we clearly wouldn't use propranolol. Atenolol has somehow fallen off the radar. There's no atenolol trial for heart failure anyway, so you can't use atenolol for heart failure. So I think your choice would really be between these three or four beta blockers. And if you're a heart failure patient, then clearly between these three. The the nebivolol trial was only in the elderly, the senior trial. It was not specifically a heart failure trial.
Right. Then the next question we have from Dr. Sandeep, that with current hypertension guidelines recommending beta blockers in selected scenarios only. So, like, how many patients do you see in your clinical practice who have heart failure but are also hypertensive?
Quite a few. Heart failure, hypertension is quite a common factor. Uh, so hypertension and coronary arteries are two main factors related to heart failure, and of course with diabetes thrown in. Now, any number of patients that we see have diabetes and hypertension as a, I mean, in my clinical practice, I mean, like most of the patients seem to have either high blood pressure, diabetes, or both, and then they come to you with coronary artery disease. So this combination of three is extremely common. So uh, I think seeing hypertension with heart failure is not uncommon at all, except when you come to severe heart failure, because then many of these patients, the blood pressure starts dropping. And in fact, in severe heart failure, the problem becomes the other way around. You can't use these drugs because the blood pressure is too low. So in that situation, there's a problem exactly opposite. The blood pressure is too low and you can't start the drugs. But in patients who are not in such severe heart failure, and many patients with hypertension per se and mild heart failure will require treatment of the hypertension. And as you know, the recent guidelines on hypertension, especially in those with heart failure, coronary artery disease, renal function, diabetes, is very strict control of blood pressure. So do not accept blood pressures of 140, 150. Try and bring it down to 120. So clearly, if the patient can tolerate blood pressure, bring it down to 120. Even if the patient is old, even if the patient is elderly, as long as the patient does not have postural hypertension or symptoms of postural hypertension, And as long as there is no worsening of renal dysfunction, so no renal dysfunction, no postural hypertension, BP is 120, patient's 95 years old, and still benefit.
Right. Then, sir, there is next question by Dr. Sonam. That in Indian patients, as we know that Indian patients have long-standing hypertension and they rarely get checked themselves. So whenever they check for heart failure, it is always there is some kind of ventricular dysfunction present at the time of diagnosis. So in this hypertensive patient, how early do you consider starting a beta blocker? And what factors do you like check in these patients to start the beta blocker?
Yeah, so let's see a patient who comes with hypertension. Now, the thing is that we recommended that everybody should have their blood pressure checked at the age of 18 years. So when during school, end of school, because joining a job, randomly check BP of all the relatives who come to the hospital, put BP machines in the malls and things. So try and measure as many people as possible because many people are simply missed. So it's clear that we need to pick up all the patients' hypertension. Once hypertension is detected, then it's very important that we treat the patient. And once we treat the patient, very important that we achieve the guidelines. Nothing happens. None of the three things happen. So we have to work on all the three things. If you have a patient who comes with hypertension, he may or may not go into heart failure. That's correct. So it's not necessary that every hypertension who presents to you should be started on beta blocker. So a patient who has hypertension and who's got reduced ejection fraction, beta blockers definitely. If the patient's got hypertension and say supraventricular tachycardia or atrial fibrillation, then definitely beta blockers would be useful. If the patient's had hypertension and myocardial infarction, but ejection fractions is still about 45, 50, yes, beta blockers would be useful. But in a patient who's got a completely normal echocardiogram, no evidence of other things except hypertension, beta blockers doesn't become mandatory or a number one drug of choice.
So then there are like how many, which are the subsets of patients who benefit from starting ivabradine?
Why would you use ivabradine? The question is, you'd use ivabradine if somebody is tachycardic. If somebody is tachycardic and say with hypertension or tachycardia with heart failure, I think beta blocker would be a better drug to use. So clearly, you would use beta blocker as the first drug. The problem is if you use beta blocker and the patient gets hypotensive, then what do you do? Or using beta blockers and the patient is not tolerating beta blockers because of asthma, other issues which are there. In which case, you can combine beta blockers with ivabradine. So ivabradine is specifically only for control of heart rate if it cannot be controlled with beta blockers or beta blockers are contraindicated. So ivabradine has a very specific role. Controlling heart rate is extremely important. We know there are a number of trials which show that control of heart rate in patients with heart failure with reduced ejection fraction is very important. So either you control the heart rate with beta blockers, and if you cannot optimize the dose of beta blockers and the heart rate is still fast, then clearly add ivabradine. So ivabradine I would not substitute for beta blockers, but use in addition to beta blockers or in patients who cannot tolerate beta blockers.
Yeah. And in patients with like, as you told, there are severe heart failure patients who have hypertension. So in these patients, can we prefer giving ivabradine?
Yeah, it is very rare to see a severe heart failure patient with hypertension. That's not common. Anyway, it's lucky if you have one because you can start all the four drugs in proper doses. So, can you imagine? Very rarely, our patients with heart failure are on 200 milligrams twice a day of ARNI plus full SGLT2 plus full beta blockers plus full MRA. Very rarely, patient achieves maximum doses of everything because they're not hypertensive. Usually, by the time the severe heart failure comes, the blood pressure tends to drop. But if you have a patient who's got, say, uncontrolled hypertension and heart failure, first of all, use all the four pillars clearly. So use them. In spite of that, if the BP remains high, then you can add centrally acting drugs, you can add alpha blockers, you can add even calcium channel blockers, though we would usually avoid things like nifedipine and amlodipine in patients with heart failure. So I would use centrally acting drugs or alpha blockers in this group of patients, along with the four pillars to maximum dosage.
Yeah, yeah, right. So we have last two questions. So Dr. Rakesh asks that like there is underutilization of beta blockers in India. So what are the common reasons for this underutilization in Indian patients, and also how can clinicians overcome this challenge?
First of all, when you say underutilization of beta blockers. In fact, the robust trial showed that there's an overutilization of beta blockers compared to the rest of the world. So compared to the rest of the world, we in fact overutilize beta blockers. Rest of the world usually does not use beta blockers in hypertension. We use a lot of beta blockers in hypertension. So the fact is that if they're underutilized, it's mainly underutilized for patients with heart failure, where we are a little bit scared. We don't want to start them. BP is too low. There's too much heart failure. You don't want to give them beta blocker. So that's where it's underutilized. But clearly, uh, using as a primary drug for hypertension is not necessary. Most of the Western world doesn't use it. The most common combination is a RAS blocker along with a calcium channel blocker or with a diuretic. So those three drugs usually form the main basis of hypertension, either alone or combination of two or three. Now, if with the combination of all these three drugs, the patient's BP is still high, then beta blockers would definitely become important. If the patient's got tachycardia, beta blockers would become important. If the patient got a lot of sympathetic overactivity anxiety, beta blockers would become important. If the patient's ejection fraction is say 45% and hypertension, beta blockers would be very important. So I think post myocardial infarction ejection fraction, as I showed in the couple of trials. So in those group of studies, beta blockers would be very important and should be used. But in an absolutely pure hypertensive patient with no other problems, beta blockers may not be the first drug of choice.
Right. Yeah. So for heart failure, people like clinicians are thoda, like at bad foot
Yes.
to
So for
use.
heart failure, it may be underutilized, but not only is beta blockers underutilized, all drugs are underutilized. We are not using all the four drugs. Number one, we are not using proper doses of all the four drugs. We are rather anxious because the patient's blood pressure is low or because the creatinine is going up or creatinine clearance is falling. So we are anxious. We don't want harm to the patient. But if they can manage the patient and put them on good doses of all the four drugs, they'll definitely have benefit in terms of mortality and morbidity, including mortality.
Right. Definitely, sir. So, sir, last question. So, what would be the your take-home message for our audience today regarding the role of beta blockers?
Well, as we discussed in the whole last 1 hour, I think beta blockers form an important part of treatment. There's no question about it. The beta blockers have been there for ages. Number two, do not use atenolol and propranolol because you don't have much data on that. You've got many other beta blockers. Four, as I mentioned, we mentioned metoprolol, carvedilol, bisoprolol, nebivolol. So use one of these. For heart failure, I would stick to the three, not nebivolol, but definitely the other three. For hypertension, I would use it as a added drug rather than as a primary drug, unless in the few patients who are very young and very sympathetically overactivated. Yes, but otherwise, I would use it in a combination with RAS blockers so that it have the RAS blocker benefit must be taken when you're treating patients with hypertension. We know that RAS blockers produce reduction of left ventricular hypertrophy, benefit for heart failure, renal benefits, etc. So they clearly have a very important role to play. In patients who got heart failure with reduced ejection fraction, less than 40%, it's mandatory and must, and please optimize the dose. In patients who got coronary artery disease angina, definitely if the angina is not corrected, you must use beta blockers. If the patient's got angina and tachycardia, beta blockers. If the patient's got arrhythmias, for example, atrial fibrillation, you can use metoprolol or sotalol. If you've got sinus SV tachycardias, you've got ventricular premature beats, beta blockers are very important, whether or not the patient has heart failure. In the post-MI situation, that's where the controversy really comes. In a post-myocardial infarction situation, if the patient has been treated promptly and the ejection fraction is completely normal, more than 50-55%, then beta blockers do not have much role to play. In the post-MI situation, if the ejection fraction is between 40 and 49, that means the mid-range, then yes, the studies have shown that beta blockers are useful and beneficial and should be started for these patients. In patients with myocardial infarction and ejection fraction is less than 40%, absolute must, it must be started. If the patient has an improvement in ejection fraction, then you can decide whether to continue or stop. Usually, suggestion is that if the patient's heart function is normal and patient has taken beta blockers for 1 year, it may be appropriate to stop at that stage. But there's one trial, the ABBIS trial, which suggested that the patients on long-term chronic beta blockers don't suddenly withdraw them because you might produce harm to these patients. So be a little bit careful, maybe withdraw them slowly. So clearly, beta blockers do have an important role in the post-myocardial infarction situation, even in the presence of correction with angioplasty. Now, you must realize that if the patient's ejection fraction improves, so this is the patient group with a reduced ejection fraction whose heart function improves and becomes normal. there are now a number of trials to suggest that do not stop the drugs. Because if you stop the four pillars in a patient whose heart function has normalized, then the patient will deteriorate again. Unless there's a very specific indication, like patients had an acute viral myocarditis and ejection fraction is low, and that has been treated. Patient has postpartum cardiomyopathy and that has improved, that may not require a lifetime. But otherwise, most patients with heart failure, which we see the common 90% patients with heart failure, once the ejection fraction improves, do not stop the drugs, continue all the drugs, including the beta blockers. This is very important.
Thank you so much, sir.
Beta blockers also are useful in patients, for example, with hypertrophic cardiomyopathy. We are using them, one, to reduce the inotropic activity. Number two, because they often have sudden death and arrhythmias. So beta blockers also a part of hypertrophic cardiomyopathy, where the ejection fraction is obviously not low, but there are other reasons for use of beta blockers.
Definitely some beta blockers now, right now, we like it has a very big role in heart failure with reduced ejection fraction. Just the clinicians must have to start using it much more robustly. Yeah. So now as we come to the end of this meeting, I would like to thank our esteemed speaker, Dr. Jamshed Dalal sir, for your time and for sharing your experience and knowledge to us. It definitely would help the audience and all the clinicians in their practice. Also, I would like to thank our audience for taking their time and attending this session, and also keeping it more interactive. I would also thank our technical partner, DocMod, for their seamless support. And with this, I end this meeting and I wish everyone a very good night. Thank you
Thank
so
you.
much, sir.
Thank you so much.
It
Bye,
was,
Casey. Thank you
bye.
for the questions.